Hi, I'm Sarah Singer. I'm a professor of healthcare management and policy here at the Harvard School of Public Health. In this class session, we're going to briefly review the history of quality improvement in healthcare. My objectives are for you to appreciate the long and sometimes difficult path of quality improvement in the United States and to understand the major differences in mindset represented by the shift beginning in about the 1980s from quality assurance to quality improvement. So to begin, let's introduce some of the pioneers in healthcare quality. Going way, way back to Hippocrates in ancient Greece, Hippocrates instilled in medicine the ethic of above all doing no harm. This dictate is still one of the principal precepts of bioethics that all medical students are taught in school. It may be better to do nothing than to risk doing more harm than good. Fast forward to the mid-1800s, Florence Nightingale was a nurse during the Crimean War. She drastically cut fatality rates among wounded soldiers by encouraging hand washing and other simple measures of sanitation, and by persuading others to comply with recommended practices through meticulous documentation of her results. Then shortly after the turn of the next century, Flexner contributed to quality improvement through his report, which revolutionized medical education. Just a few years later, Ernest Codman, a surgeon at the Mass General Hospital, pioneered outcomes measurement and use of outcomes for quality assurance. Eventually, the American College of Surgeons adopted Codman's system, but not before MGH withdrew his admitting privileges at the hospital. The federal government also played a role in quality by enacting important legislation like Medicare and Medicaid, which greatly expanded access to more and better care. Of course, they've done so again with provisions affecting quality in the Affordable Care Act, but those are conversations for other class sessions. The last in this group I'll mention is Avidis Donabedian. A physician, he was the person who proposed the structure process outcome model, which is still widely used as a framework for studying quality. The modern quality improvement revolution is generally attributed to a similar revolution in industry. After World War II, U.S. manufacturers found themselves falling way behind Japan in both quality and cost. When they finally started to ask why, they learned that Japanese companies had been taking advice from American quality experts, especially Edward Deming and Joseph Juran, whose methods built on those of statistician and engineer Walter Shewhart a decade earlier. Key ideas they advocated included streamlining production processes, minimizing opportunity for human error by hardwiring the ways people do work, standardizing work processes, making decisions based on data, and establishing commitment to improvement all the way from the top down through the front lines. By the mid-1980s, healthcare leaders like Donald Berwick saw the quality gains in manufacturing and wondered if the same could be done in healthcare. They initiated the National Demonstration on Quality Improvement in Healthcare, and they paired leading healthcare organizations with companies like Xerox, Bell Labs, Hewlett-Packard, and Ford Motor Company. And together, they proved that quality improvement methods could work in healthcare. A major outcome of the National Demonstration Project was a shift from quality assurance on the one hand to quality improvement. Both, however, are still used, so it's important to understand how they compare. This chart highlights some of those differences. So first, the underlying belief about how quality is produced is different. In quality assurance, the underlying belief is that quality is the product of individuals. And in quality improvement, the underlying belief is that quality is a product of systems. Correspondingly, the objectives are different. In quality assurance, the objective is to meet minimum quality standards. In quality improvement, the objective is to prevent or to decrease the likelihood of quality problems. The approaches are also different. In quality assurance examines retrospectively why organizations failed to meet a given standard. Quality improvement looks prospectively and prospectively tries to review processes in order to identify opportunities for continuous improvement. The responsibility for quality is also perceived differently in these two approaches. In quality assurance, there's a quality assurance officer or a risk manager who's responsible for quality for the organization. And under quality improvement, there's a very strong belief that responsibility rests with everyone in the organization, including frontline workers, who are considered to be frontline experts because of their deep understanding of what goes on at the front lines. There's a role also in quality improvement for patients and family members and other informal caregivers because there's a recognition of their important role in making sure that they receive high-quality care. With the evolution of quality improvement has come an evolution in its objectives and in the way we evaluate quality. Stewart, Deming, and Duran, and others who advocated total quality management and other related techniques focused our attention on things like fitness for use or meeting customer needs, on reducing defects down to negligible levels, on focusing on systems rather than on individual level quality, and on reducing variation in processes. In 2001, the Institute of Medicine, through a series of reports, gave us a broad definition of quality that included 6 aims. Care should be safe, it should be timely, it should be effective, it should be efficient, it should be equitable, and it should be patient-focused. And then in 2010, the Institute for Healthcare Improvement focused our attention on the triple aim. We need to simultaneously improve the patient experience of care while moving beyond the individual to improve the health of populations, and at the same time, we need to focus on reducing per capita costs of healthcare. I want to conclude by recognizing some of the major approaches for quality improvement. First, measurement and public reporting. The National Committee for Quality Assurance kicked off this approach by publishing comparative data about health plans in their Healthcare Effectiveness Data and Information Set, or HEDIS measures. Dartmouth made a major contribution through its ATLAS reports, which demonstrate wide and unwarranted variation in resource use across the United States. And the government, now with multiple healthcare compare websites, provide comparative information about all sorts of providers. These and many others are focused on measuring and publicly reporting data. Another approach is incentive schemes, like pay for performance and bundled payments, which aim to improve quality by making quality pay. Multi-organization quality improvement collaboratives like IHI's Breakthrough Series have become popular ways for organizations to gain expertise and to share learning while they focus on specific quality improvement topics. Campaigns like the American Heart Association's effort to reduce door-to-balloon time and IHI's 100,000 Lives campaigns. These encourage widespread adoption of bundles of evidence-based practices to improve in particular areas. And finally, simulation techniques, by which I mean everything from opportunities for practitioners to role play offline to high-tech centers with mannequins and complete with respiratory functions and vital signs. These simulations let multidisciplinary teams practice delivering patient care without the possibility of harming real patients. These represent a relatively new but critically important approach to quality improvement. That was a brief history of quality improvement in healthcare. Thanks very much for your attention.